Have you ever swallowed and swallowed again just to check if something was really there? Not pain, not quite discomfort, something closer to a fullness, a low pressure sitting at the base of your throat like a coin lodged sideways, except nothing is lodged anywhere. You drink water, it's still there. You clear your throat, and for one hopeful second it feels like it moved, and then it settles right back into the same spot. If you've ever lived with that sensation for weeks, or months, or years, I want you to keep listening because what I'm about to explain is something almost nobody gets told in a normal doctor's visit, and it might reframe everything you thought you understood about your own throat. Millions of people search for this feeling every single month. They type things like lump in throat that won't go away, or constant need to clear throat, or throat mucus feeling for no reason. And what they usually find is a short list of familiar suspects: allergies, post-nasal drip, dry indoor air, anxiety, acid reflux, maybe, if a doctor is being thorough. They get handed an antihistamine or a nasal spray or advice to drink more water and see if it settles. And for a small number of people that actually works. But for a much larger number, none of it touches the sensation at all. The mucus feeling stays exactly where it was, indifferent to every remedy thrown at it, and the not knowing becomes almost as exhausting as the symptom itself. Here's the first thing worth sitting with. When a symptom refuses to respond to the obvious fixes and refuses to follow the obvious patterns, that's not randomness, that's information. A cold clears in a week or two. Seasonal allergies rise and fall with pollen counts. A dry throat responds, at least partially, to humidity and hydration. But this particular sensation often does none of those things. It doesn't care about the season. It doesn't fully respond to water, no matter how many liters a person drinks in a day. And very often, it has a rhythm that people notice only after they've been tracking it for a while. Worse in the morning, worse an hour or so after breakfast, strangely quiet by mid-afternoon, and then building again by the next morning. That rhythm is a clue. And clues like this are usually more useful than any single test because they point toward a mechanism instead of just a label. To understand that mechanism, we have to go somewhere most people never think to look when the problem is in their throat, and that's the stomach. Specifically, a digestive enzyme called pepsin. Pepsin is not some obscure or exotic chemical. It's one of the primary workhorses of human digestion, produced by cells in the stomach lining and released into an environment so acidic that almost nothing else in the body could survive it. Its entire job is to break down protein, the kind in eggs, meat, dairy, legumes, fish, into fragments small enough for the intestine to absorb. Inside the stomach, this is a beautifully engineered system. The stomach lining is coated in a thick, protective mucus layer, specifically because it has to withstand its own digestive machinery. Pepsin, in that setting, is simply doing its job and doing it well. The complication begins when pepsin doesn't stay where it belongs. Between the esophagus and the stomach sits a muscular ring called the lower esophageal sphincter, essentially a one-way valve. When it works properly, it closes tightly after food passes through, sealing the stomach's acidic contents inside. But that valve isn't infallible. It can relax at the wrong moments, or come under more pressure than it can resist. And when that happens, stomach contents move backward, up into the esophagus. Most people know this experience under a different name: heartburn. That burning sensation behind the breastbone is the textbook version of reflux, and it's the version doctors are trained to ask about first. But there's a second version of reflux that behaves almost nothing like the first, and it's the one most relevant to that mystery throat sensation. In clinical language, it's called laryngopharyngeal reflux, often abbreviated LPR, and outside clinical settings, it's sometimes called silent reflux, for a very specific reason. It frequently produces no heartburn at all. Instead of a slow, gravity-driven wave of acid, some researchers describe it as behaving more like a fine mist or aerosol, tiny droplets carried upward, past the esophagus entirely, reaching the throat and the back of the voice box. Unlike the esophagus, that tissue was never built with a thick protective coating designed to withstand digestive enzymes. It's delicate, and when pepsin lands there, it doesn't necessarily announce itself with pain. It settles in quietly, and it can remain temporarily inactive on the tissue surface for hours, sometimes longer, waiting. That single detail is what makes this whole story counterintuitive, and it's worth pausing on. The pepsin sitting in someone's throat right now doesn't have to be actively arriving from the stomach in that moment for the sensation to be present. It might have arrived the night before. During a reflux episode nobody felt because there was no burning to signal it. It can sit there, dormant, and the throat clearing someone does at their desk at 10 in the morning may have almost nothing to do with anything they just ate. This is precisely why so many people feel like their symptom makes no sense. They're looking for a trigger in the present moment, when the real trigger might be something entirely different, something chemical, something about pH. Pepsin's activity depends heavily on acidity. At a neutral or slightly alkaline pH, somewhere around 7 or higher, it's essentially dormant. It doesn't break down tissue in that state. But drop the pH low enough, generally below 4 or 5, and pepsin reactivates, behaving almost exactly as it would inside the stomach, except now it's acting on delicate laryngeal tissue that was never designed to tolerate it. And here's the part that changes how people think about their own daily habits. The acid that reactivates pepsin doesn't have to come from the stomach itself. It can come from what a person eats or drinks. Coffee typically sits somewhere in a moderately acidic range. Orange juice and other citrus are more acidic still. Tomato-based foods, carbonated drinks, wine, vinegar, all of these can lower the pH right at the throat's surface as they pass through. And if there's already pepsin resting there from an overnight reflux event, that morning coffee or glass of juice can be the very thing that wakes it back up. Once pepsin becomes active on that tissue, the body responds the way it responds to any irritant. Inflammation increases, and along with it, mucus production rises as a protective measure, the tissue essentially trying to build a buffer between itself and whatever is irritating it. And this is the piece that reframes the entire story for people who've spent years being told they simply produce too much mucus, or that their sinuses are overly sensitive, or that they're unusually attuned to normal bodily sensations. In a meaningful number of cases, what they're feeling isn't excess mucus from allergies or dry air at all. It's the throat's own defensive response to an enzyme that was never supposed to be there in the first place. Picture a version of this story that plays out in clinics constantly, a composite rather than any one identifiable person, but familiar enough that specialists recognize it within minutes. Early 60s, meticulous. 2 years of throat clearing, 3 doctors, 1 useless course of antibiotics, antihistamines that barely dented it. A laryngoscope eventually shows no mass, no obstruction, just mild redness and thickening on the back wall of the larynx, right behind the vocal cords, with no infection anywhere near it. That single finding, posterior laryngeal irritation without a bacterial cause, isn't proof on its own. Other conditions can look similar. But paired with the right history, it stops being a mystery and starts being a testable pattern. And the pattern usually hides inside something as ordinary as a morning routine. Coffee first, then orange juice. Then, because the throat feels awful, extra water all day long, starting with a big glass right after breakfast, in the hope that flushing the area will wash the problem away. This is exactly where hydration hits its biological ceiling. Water rinses. It doesn't dissolve. Think of grease on your hands after working under the hood of a car. Running them under a kitchen tap moves water across the grease without lifting a trace of it, because plain water was never built to break that kind of bond. Pepsin clings to throat tissue the same stubborn way. And if it gets reactivated by acidic food or drink every single morning, the throat clearing symptoms simply reset, day after day, no matter how much water goes down. That's the moment the 2-year mystery usually clicks into place. The orange juice wasn't harmless. It was reactivating an enzyme laid down hours earlier by a reflux episode nobody felt, because there was no heartburn to announce it. The coffee compounded it. The water rinsed the surface and left the cause untouched. By evening, another silent episode restocked the tissue, ready for the next morning's coffee to switch it back on. It's a closed loop, easy to run for years without noticing, because from the outside it looks like nothing more than a normal, healthy breakfast. Before going further, it's important to be honest about where the boundaries of this explanation sit, because responsible health information should never encourage anyone to talk themselves out of medical evaluation. If someone is experiencing real difficulty swallowing, where food or liquid seems to catch or stop on the way down, or pain specifically when swallowing, or unexplained weight loss they can't otherwise account for, or any sign of blood, or a new lump in the neck that isn't going away, or a genuine and lasting change in voice quality that persists for more than 2 or 3 weeks, none of what follows applies to that situation. Those signs call for direct medical evaluation, promptly, not a video, and not a home strategy. But for the far more common presentation, a chronic throat clearing sensation, a feeling of mucus or fullness that doesn't resolve, without those warning signs present, the mechanism described here is genuinely relevant, and understanding it can change the entire trajectory of how someone approaches their own care. There are, broadly, 3 levels at which people can think about addressing this, and they work through different mechanisms entirely, which is exactly why so many people try one thing, feel a small improvement, get frustrated when it doesn't fully resolve the issue, and give up before ever trying the others. The first level, and often the fastest form of natural relief for silent reflux symptoms, concerns pH directly at the site of irritation. If pepsin is only dangerous in an acidic environment, raising the pH at the throat's surface can put it back to sleep, at least temporarily. That's the logic behind alkaline gargling for throat mucus and post-nasal drip-like symptoms. A small amount of baking soda dissolved in water, gargled deeply at the back of the throat for roughly 30 seconds, then spat out. Sodium bicarbonate raises local pH, and many people notice measurable relief within a day or 2. Some clinicians also recommend high pH alkaline water in the range of 8 or above, sipped steadily through the day as a gentler, ongoing version of the same idea. One caveat matters here. Anyone with kidney disease, poorly controlled blood pressure, or a sodium-restricted diet should check with whoever manages that condition first, since the sodium load, while small, can interact with both kidney function and certain medications. The second level is a class of natural reflux remedies called alginates, derived from brown seaweed, and the mechanism here is entirely different from alkalinity. Taken after a meal, alginates mix with stomach contents and form a physical gel, often called a raft, that floats right at the junction between the stomach and esophagus. It doesn't touch acid production at all. It simply blocks the path, so when stomach contents get pushed upward by lying down, bending over, or ordinary pressure changes, the raft intercepts them before they can travel further. Studies on laryngopharyngeal reflux treatment have found alginates genuinely useful precisely because they work preventively, stopping material before it ever reaches the throat, rather than mopping up damage afterward. Timing is everything. They need to go in within 20 to 30 minutes of eating before stomach contents have had a chance to shift, and a large glass of water right after can wash the gel away before it fully sets. A small detail that quietly explains why some people try alginates once and write them off. The third level is the most demanding and often the most revealing, a structured LPR diet elimination trial. 2 to 3 weeks, no weekend exceptions, removing the foods most likely to reactivate pepsin, citrus, tomato-based foods, coffee, carbonated drinks, alcohol, mint, large meals, and anything eaten within 2 to 3 hours of lying down, since a full stomach under pressure pushes upward regardless of pH. None of these foods are dangerous in a general sense. The issue is only that against pepsin already resting on inflamed tissue, they act as chemical triggers. Reintroducing them one at a time afterward turns a vague suspicion into real, personal data. Some people find coffee is doing nearly all the damage. Others find the list barely matters, which tells them the reflux frequency itself, not any single food, is the variable worth chasing. Here's the honest limit of all 3 levels. They manage pepsin damage. They don't repair what let it travel there in the first place. Alkaline gargles, alginates, dietary changes, all of them reduce the injury after reflux has already happened. None of them fix a lower esophageal sphincter that isn't closing properly. Think of a leaking ceiling. A bucket underneath catches the water and saves the floor, which is genuinely useful. But the roof is still broken, and the leak keeps coming until someone deals with the source. Addressing the source usually means looking at the factors that influence how often and how forcefully reflux occurs in the first place. Meal size and timing relative to lying down. Sleep position, since lying flat, especially on the right side, can make it easier for stomach contents to move upward compared to sleeping on the left side or with the head slightly elevated. Certain medications that relax the lower esophageal sphincter as a side effect. Abdominal pressure, whether from tight clothing, excess weight around the midsection, or conditions like a hiatal hernia, where part of the stomach shifts upward through the diaphragm and changes the mechanics of that valve entirely. These are the variables that determine not just whether pepsin lands somewhere sensitive, but how often it happens and how much of it there is each time, and they're worth a longer, separate conversation with a physician who can properly evaluate them. There's also a connection worth knowing about if diabetes is part of someone's health picture, because it illustrates just how interconnected the digestive system really is. Certain medications commonly used to manage blood sugar, including metformin, can affect gastric motility, meaning the rate at which the stomach empties its contents into the small intestine. A stomach that empties more slowly holds food and acid longer, which increases pressure at the junction with the esophagus and raises the likelihood of reflux, including the silent kind that produces no burning at all. Anyone managing diabetes who has also been dealing with unexplained throat clearing might reasonably ask their prescriber whether medication timing or type could be playing a role. It's a specific, useful question, and specific questions tend to get more useful answers than vague complaints. That really is the broader lesson sitting underneath all of this. Patients who walk into an appointment with observations, not just complaints, tend to get to the right answer faster. Noticing that a symptom is worse in the morning rather than the evening. Noticing whether it tracks with certain foods or certain seasons. Noticing whether it changes with body position or stress or sleep. That kind of specificity transforms a 15-minute appointment that ends in a generic prescription into one that ends in a genuine explanation, because it gives a clinician something concrete to work from instead of a vague, familiar complaint they've heard 100 times before without enough detail attached to distinguish one cause from another. If you've been living with chronic throat clearing that mucus sprays, antihistamines, and gallons of water haven't touched, it might be worth asking your doctor one specific question, whether what you're feeling could be pepsin sitting on tissue that was never built to handle it, rather than ordinary sinus mucus. That single, precise question can redirect an entire course of care. And maybe that's the real lesson here, far beyond one throat symptom. The body rarely shouts before something is serious. Most of the time, it whispers, patiently, for months or years in whatever language it has left, waiting for someone to finally ask it the right question.